Good afternoon, everyone. Thank you for joining us. We will be recording the formal presentation portion of this book discussion for week 2, and we'll give everyone about a minute or two to join us, and then we will start today's discussion with Dr. Hoffman.
Is there going to be a Q&A after my talk, or how does that work? Because I'm going to have to leave early.
Yes, so about 5 minutes or so right after your presentation.
Okay.
We'll make sure that you're out on time. And without further ado, I have the privilege of introducing Dr. Hoffman. She joined the faculty in 1999. She is the Edgar A. Hahn Professor of Law, Professor of Bioethics, and co-director of the law school's Law Medicine Center. Professor Hoffman served as Associate Dean for Academic Affairs from 2006 through 2009. She teaches health law courses, employment discrimination, and civil procedure, and was voted First Year Teacher of the Year in 2011, 2012, and 2019. She has won several other distinctions for her teaching and scholarship, including, most recently, the 2021 Case Western Reserve University Faculty Distinguished Research Award. Dr. Hoffman was elected to membership in the American Law Institute in 2017. In 2013, Professor Hoffman was selected by the Robert Wood Johnson Foundation for a Scholar in Residence Fellowship in Public Health Law. She has also twice spent a sabbatical semester as a visiting scholar at the Centers for Disease Control and Prevention in 2007 and 2014, and was a visiting scholar at Emory University in 2014 as well. During her spring 2022 sabbatical, Professor Hoffman served as a visiting scholar at the National Institutes of Health Bioethics Department. Professor Hoffman has published over 70 articles and book chapters on health law and civil rights issues. Her areas of focus include health information technology, aging, and disability law. Her work has appeared in the Georgetown Law Journal, William and Mary Law Review, Boston College Law Review, New England Journal of Medicine, and JAMA, among many other journals. Professor Hoffman was named the 9th most cited health law scholar in the United States from 2016 through 2020. She is the author of 2 books, Aging with a Plan, How a Little Thought Today Can Vastly Improve Your Tomorrow, and Electronic Health Records and Medical Big Data, Law and Policy. Professor Hoffman has lectured throughout the United States and internationally, and frequently appears in the media. Dr. Hoffman, the floor is yours.
Wonderful. Thank you so much. I'm going to see if I can manage to share my screen. Okay, there we go. Well, I am going to be talking today about artificial intelligence and focusing on discrimination concerns that arise from artificial intelligence. But I thought I would start with some good news. Why is there so much enthusiasm about artificial intelligence and algorithms in healthcare? Well, they really can improve healthcare outcomes. For example, they can help doctors identify patients who are at risk of complications and hospital admissions. There's a lot of work being done here at Case Western on analyzing tumor images in order to determine just from the image which ones are cancerous and which ones are very aggressive, so that you would immediately give people with aggressive tumors chemotherapy and other treatments, but you could spare people who don't have aggressive tumors very uncomfortable treatments. And Algorithms have also been used to identify candidates for clinical studies so we can better do medical research. There are, however, concerns, and one non-discrimination concern is sort of interesting. It's about the physician-patient relationship. So some people worry that physicians might actually become redundant, that medicine will evolve into a practice where you input information in a computer and the computer spits out a diagnosis and treatment plan, and what is the doctor's role going to be? So we're far from that, but it is a topic of discussion. Also, if an algorithm recommends that you not give a cancer patient chemotherapy, for example, are doctors going to trust that? Or are they going to be too concerned about liability and give everyone aggressive care nonetheless? And how are we going to analyze liability? Are doctors going to be able to defend themselves and say, oh, the computer told me to do it, it's not my fault, even if there's a bad outcome? So those are some interesting concerns. But I do want to focus on discrimination because these sessions are about health equity. So we know that in a lot of other areas, algorithms have clearly caused very significant discrimination. For example, in the criminal justice area, they use algorithms in order to try to determine or predict which defendants are going to re-offend. And so you can tailor punishments based on that. You can decide whether to let them out before trial, pending a conviction, and so on. And not surprisingly, it's been shown that these algorithms often mislabel Black defendants as likely to reoffend and mislabel white defendants as unlikely to reoffend, even when that's not what actually happens. In the area of hiring, there was a famous case of Amazon trying to use an algorithm to determine which resumes to pick out of the pile for purposes of interviews. And the algorithm generally rejected women and selected men. And that was because it was trained using primarily male resumes. So the way you get an algorithm to work is you train it, you show it what to do using a particular data set, and then it learns how to analyze new information. And in this case, the training data was skewed and messed it up. With respect to housing, a Facebook algorithm kept minorities from seeing housing ads in areas that were considered to be white areas. So I know that we see discrimination all over. I was curious to see if that is also true in the healthcare field. And you will not be surprised to learn that, yes, there is AI discrimination in medicine as well. And there are lots of anecdotes. I'll just give you a couple. There was an algorithm that was used to determine which patients should be referred to high-risk management programs. These are very helpful and supportive programs that provide resources to people with serious chronic diseases. But this algorithm generally did not refer African Americans for these helpful programs. It referred white people. And the reason for that was that it was trained to use past medical expenditures as a proxy for medical need. So if you spent a lot of money, it assumed you were very sick and you needed this high-risk management program. If you didn't spend a lot of money in the past, it assumed you were healthy. But of course, African Americans often face access barriers. They either don't have money to get medical care, or there are other barriers such as childcare, transportation, and so on. And so this algorithm was very misleading, and it actually deprived people who needed the support the most of this program. In Toronto, they were using they designed an algorithm to try to determine which people had early Alzheimer's disease. And what this algorithm did is it analyzed speech samples. But the problem was that the speech samples on which it was trained were of native English speakers who had a particular Canadian dialect. And of course, in Canada, you have a lot of native French speakers and different dialects. And this algorithm mistook anyone who had a foreign accent or who had some pauses and hesitations because English wasn't their first language. It mistook them to have cognitive decline. So it worked well for the native English speakers, but not for anybody else. And then there are actually algorithms that do race corrections. They adjust based on your race. So they will give you more or fewer points depending on whether you are Black or white. And so they do that in order to determine who has heart failure, for example, or who has kidney stones when they come to the emergency room. And the NFL infamously did this when it analyzed cognitive function test scores in order to determine settlement amounts for people who had brain injuries due to concussion. So it would add or subtract points based on your race. Now, the reason they do that is because there are studies that show that heart failure and kidney stones and other things are more or less common in certain populations. But of course, just because it's more common doesn't mean that a particular individual won't have this condition when they come to the emergency room. So these algorithms are overgeneralizing, or they're trying to adjust for socioeconomic factors. And while it's true that as a matter of generalization, African Americans don't score as well on cognitive tests, that may not be true for any particular individual. So it's very problematic to have these overgeneralizations. Why do we have algorithmic bias? As I've already suggested, one major reason is deficiencies in the training data. If your training data doesn't have women or doesn't have African Americans, when you try to generalize the algorithm to work well for everyone, it will not work well for the people it wasn't trained for. Poor design. That is also often true, and I provided the example of the algorithm that used past medical expenditures as a proxy for medical need without taking into account access barriers that minorities may suffer. And then when we talk about the concept of race, that in itself is problematic, because what does race mean? It is really a social construct, a fiction. In the healthcare setting, we're often talking about genetic variations that might be more or less common in particular populations. But if the issue is a genetic variation, then the algorithm should focus on the genetic variation and not make determination based on whether somebody is identified as white or Black. Or it might be a matter of social determinants of health. Some people don't have a good level of education or nutrition or exercise and so on. But again, you cannot overgeneralize based on whether somebody looks white or Black. The algorithm should analyze those social determinants of health. And of course, we have many, many people, millions of them, of mixed ancestry. And if the algorithm is supposed to treat Black people and white people differently, what do you do about people who have mixed ancestry? So just briefly, some recommendations. Algorithmic fairness should really be a key element of designing, validating, and implementing AI. So anyone who designs algorithms or uses algorithms should be very sensitive to the problem of potential bias, of potential discrimination, and do whatever is possible to address it. But we also have to understand that fairness is a very complicated concept, and often you have trade-offs. So if you're going to adjust your algorithm and try to promote fairness, you may have to make some choices. You may prioritize group fairness, but at the cost of sometimes not achieving fairness for particular individuals. Or you may emphasize fairness of process, but at the cost of fairness of outcome for some individuals. So there are often choices to make, and we cannot just naively talk about algorithmic fairness. Now, I'm a law professor, so I'm always interested in law reform, and there actually have been a variety of proposals to try to address algorithmic bias and to try to make people liable for discrimination that is associated with use of algorithms. None of these have passed yet, but there is an HHS, a Department of Health and Human Services proposal for a regulation that may well pass. And I think addressing it at the legal level is useful and important. So we'll see what happens. And I think I will stop there, and I'm happy to take some questions.
Thank you, Professor Hoffman. If anyone has questions, you can type them in the chat, or you can take yourself off mute.
Hi, Professor Hoffman. I'm Rachel Oscar from the Mount Sinai Health Foundation. Curious where, outside of just health, have we seen any legal reforms regarding AI, like in the landscape in general? Like, is it possible?
Yes, so there have been major proposals, and then there are some localities, just 2 or 3 that I'm aware of, that have actually passed a regulation that if the city is going to use algorithms for various purposes, they must avoid, to the extent possible, having those result in discrimination. So at the local government level, there have been some initiatives that have passed, but it's also very difficult, I think, to make users responsible for algorithmic bias because, are they supposed to do studies? They're not the experts. They're not the ones designing it. In the medical field, doctors are overwhelmed and burnt out and so on. Are we going to add the responsibility? Now carefully look at all of your patients, determine if this algorithm is generating discriminatory results. So it's very, very challenging because lay people are using it and they may not have the tools to address bias.
Thank you.
Hattie?
Yes, I'm a student at Case Western Reserve. I was just wondering if you can elaborate on the complexity of fairness concept. I'll turn my camera on.
Right. It's just, you cannot just say, oh, we're going to achieve fairness and it's going to magically happen. There often are trade-offs. So if you want to be fair to all African Americans and you want to adjust your algorithm in particular individual cases, that might actually not be fair because particular individuals may not have the genetic variation or may not have access barriers and so on. So they provide the example of a bank wants to make sure it doesn't discriminate with respect to loans. And so it can make various rules, right? It wants to provide more access to African Americans who generally have a lower income. And so it will say, okay, we're going to prioritize people with less than $70,000 in annual income. Well, that's great. That will help people who have less than $70,000 in income, and it will probably help African Americans more so than whites. But in particular cases, that's really unfair because what if you have $74,000 in income and you really need the loan and they're not giving it to you because they've made a rule that promotes group fairness but de-emphasizes individual fairness. So that's a particular simple example. Is that helpful?
Yes, thank you. But also, what do you mean by process versus outcome?
Right. So For example, in the law, you might want to emphasize having a really fair and elaborate process. So everybody gets time to investigate and look at documents and have a hearing and so on. And that's a really good process. But for particular individuals, it might be much more helpful to just, it's a simple case, you just resolve it quickly without all that discovery and hearing and so on. And so building a really fair process might actually be disadvantageous for certain people who just want a quick outcome and really need the relief quickly. So that's another simple example.
Okay, thank you.
Thank you for the great questions, and thank you, Professor Hoffman. Dr. Hall, if you'd like to queue up your slides, I will proceed with your introduction. Dr. Greg Hall is a primary care physician practicing in Cleveland, Ohio for over 25 years. He is the author of Patient-Centered Clinical Care for African Americans, a concise, evidence-based guide to important differences and better outcomes. The book, written for medical providers and the first of its kind, gives best practices in the clinical care for African Americans. Dr. Hall has a dual appointment on the teaching faculty at Northeast Ohio Medical University College of Medicine as associate professor of both internal medicine and integrative medical sciences. He is also an assistant clinical professor and has an appointment at Case's School of Medicine. He is currently the medical director at the UH Cutler Center for Men and board chair and founder of the National Institute for African American Health. In 2002, Dr. Hall received a governor's appointment to the Ohio Commission on Minority Health and served as chairman until the fall of 2018. He also serves on Ohio Medicaid's Medical Care Advisory Committee. In 2010, he was appointed to the Cuyahoga County Board of Health, which oversees Ohio's second largest county's public health programs and services. In 2020, he began serving as the board's president. He has lectured on various topics ranging from hypertension to permanent body art to health disparities, but his latest passion is to improve the general public's knowledge about the important differences and needs in the healthcare of African Americans. Dr. Hall, you may begin.
Thank you. Everybody hear me okay?
Yes.
Excellent. Thank you. Thank you. And this is going to be a whirlwind. So I was putting this together, so just bear with me. But I thought it was interesting. I had never seen this quote before you put this together. It's more important to know the sort of patient, what sort of patient has the disease and what sort of disease a patient has. I mean, that's deep, and that's Sir William Osler. And that really speaks to what we're talking about. And as was done and Professor Hoffman's talk, I mean, you can't paint African Americans with one broad stroke. I mean, there's differences, right? But what you do need to know is that there are, in some cases, these histories, like that I'm going to talk about, are important. In some cases, the socioeconomic status is important. In some cases, their family histories are important, and so we don't want to lose those. So I start with the facts, just the facts, ma'am, right? So this is the latest vital statistics. Life expectancy 2019 is the latest one that we have, and just sort of think. I've only 11 minutes. I want you guys to think about whose life expectancy is what on this. Who's 74.8? Who's 78? Almost 79. Who's almost 82? Who's almost 86? Life expectancy at birth by race or ethnicity. And since I'm talking, African Americans are the 74.8. But I want you guys to think about who's 79, who's 82, and who's 86. I'm only going to give you a couple more seconds because I'm going to run through a lot of slides because people are surprised by this. But so whites are almost 79. Hispanic Latinos are 82, and Asian Pacific Islanders live to be, on average, men and women combined, 86. So when I was appointed back in 2002 to the Ohio Commission on Minority Health, I thought minorities had bad outcomes and the majority, white people, had the best outcomes. So it was surprising to me to find out Hispanic Latinos and Asian Americans live longer, significantly longer than both African Americans and whites. And when I agreed to come to be the medical director of the Cutler Center for Men, you know, that really was because I do health disparities, and there's a significant health disparity for white men compared to Hispanic, Latinos, and Asian Pacific Islanders, and also still African Americans. So it's sort of interesting. Now, this breaks down women and men. And again, fascinating for me, average life expectancy at birth for an Asian female, 87.4, Asian American, Hispanic female, 84.5, Asian male, 83, white female, 81.3, Hispanic male, 79.1, Black female, 78.1, white male, 76.3, Native American or Alaskan female, 75, African American male like myself, 71.3, and then the Native American or Alaskan Native, 68.6. So that's the breakdown across races and ethnicity. So you see Native Americans and Alaskan Natives are doing worse than African Americans. But aside from that, I'm second from the bottom at 671. Significant, right? And this slide just shows that for the Asian American female, 80% of Asian Americans are alive at age 80. That's compared to 57% of African American women alive at age 80, 57%. 70% of Asian American men, 70% are alive at age 80, right? Compared to just under 40% of African American men are alive at age 40. So that's sort of, we talk about disparities. What contributes to those disparities? Heart disease, cancer, homicide, diabetes, those things contribute to African American disadvantage compared to the white population. And so this, not trying to be inflammatory, it's just the facts. Lifetime risk of being killed by the police in the United States. You see African Americans are first, Native American, Alaskan Natives are second, Hispanic Latinos, then total, then whites and Asian Pacific Islanders who live the longest have the least like. And then I have to point out that blue is men and red are females. And so you see a significant disparity between the odds of getting killed by police if you're a man versus a woman. And so let's look at leading causes of death for non-Hispanic, Black, African-American men. This is 2017. This was surprising to me. It's still surprising. The number one cause from age 1 to age 19, the number one cause of death is homicide. From age 20 to age 44, the number one cause of death is homicide. And then overall for African-American males, homicide is number 4. So it's just surprising to me. I have 3 African-American sons in their 20s, and their number one cause of death would be homicide. So that's why you have to worry about them out in the community. Not just police, but community, Black on Black crime, all those things. But it just was surprising to me. You think about, life expectancy, homicide is the cause. African Americans have the worst outcomes for cardiovascular disease, the worst for diabetes, and then the worst outcomes for cancer, all those listed there: breast, ovarian, cervical, colon, prostate, and so on. And so what's not there, lung cancer, whites had just edged out African Americans in terms of mortality for lung cancer, but you see African Americans have the worst outcomes for colon cancer, for breast cancer. And so this is the classic health disparity. White American women get breast cancer at a higher rate than African American women, but African American women die at a much higher rate. So that's the classic, why is that disparity? A group of people who get it less often than another group, yet have a higher mortality. So let's drive these health disparities, access, the genetic, epigenetic differences we kind of touched on earlier, patient-related differences, diabetes, diet, exercise, or lack thereof, their healthcare system-related reasons, and there's also oppression. And so I know you can't see this slide, but it says, how do we get there? But it starts with slavery and structural racism and post-emancipation, Jim Crow laws, all those things have sort of gotten to, that's the history that we have to kind of embrace that got us where we are here today. And just to run through them real quick, Jim Crow laws just enforced segregation. Separate was supposed to be equal, and those were enforced until the 1965. I was born in 61, so those were still enforced when I was a little guy. And unfortunately, separate was not equal. They had separate water fountains, things that some of you in the audience would think is distant history, but it's not that distant. It's not that distant. I went to a museum, civil rights museum in Greensboro, North Carolina, and saw this Coke machine. It's not about Coke. I like Coke better than Pepsi, put that for the record, right? But they made a Coke machine that made the temperature warmer and the cost higher on the black side. Basically, this machine would sit in a wall. One side would show on the white side of the waiting room. The other side would show on the black side that had a waiting room. The cost was higher, but the part that baffles me is that someone went to the trouble to make an engine that would make one side not as cold as the other. And so that just shows the contempt, I can't think of a better word, that what people had for African Americans. So there were colored waiting rooms. You had to sit in the balconies at hotels. I mean, this is common knowledge. Again, probably playing more. Redlining, which was done specifically to try to prop up one community and to put down another community. And it was significantly done around really communities of color, but particularly African American communities. And this happened as well. And this Baltimore talked about that because of this lawyer that had gone to Harvard and moved into a white neighborhood in Baltimore and set off a firestorm, these ordinances came forward that no Negro may take up residence within a block in the limits of Baltimore where more than half the residents were white. These were laws. These were things that were done particularly in the name of public health. Like I tell my public health workers, Blacks should be quarantined in isolated slums in order to reduce the incidence of civil disturbance, prevent the spread of communicable diseases into nearby white neighborhoods, and to protect the property values among the white majority. That's Baltimore mayor. So when we talk about saying is racism a public health concern, and should the government be concerned about racism, these were things that the government did that were racist. And so this redlining led to housing devaluation, housing decline, decrease in generational wealth. That led to foreclosures, vacancies, asset loss. And of course, you're going to get crime and safety problems, and you're going to get worse schools, you're going to get neighborhood decline. All these things contribute. Poverty, inferior schools, all driving poor health. Everyone agrees on that. So these social and financial things that they did were policy driven for segregation, but it drove poor health outcomes. And what was the cause? Racism was the cause. And so the trust issues, what about trust issues that African Americans have in health? Tuskegee syphilis story, we've heard about it ad nauseum this last couple of years. But I tell people, don't believe some stories. This was for colored people. This was fine the first 10 years until penicillin in 1942 was the cure for syphilis. So you got a cure, and someone made the decision that we're not going to treat. And that went on for 30 years. They didn't treat people with something that had a cure for 30 years. And so they have African Americans forgot about it. Over 80%, probably even higher now after the pandemic, know about the study, whereas a minority of whites, maybe more now because of the pandemic, know about it. And so that's there. Marion Sims, I've talked about it past, the father of gynecology, but he did all of his science basically on experimenting on slave girls, unanesthetized slave girls, doing gynecological surgery on unanesthetized slave girls and documenting who you did the surgery on, what you did. I'm going to try this, I'm going to try that, advancing science, but unfortunately torturing people. How did medical schools get bodies back? How did they get cadavers in order for us to learn anatomy? Apparently it was grave robbing. Who knew? And so again, article after article saying, they raided African American graves in order to provide for education at the medical schools. And again, imagine burying your husband or your wife, or your mother, your father going a week later, and someone has dug them up and taken them away, and you know who it is, not someone. It's the medical school in the next town. It was a medical student. So how does that color how you view doctors? And then again, look at this. This is the Georgia Medical College, the grave robber right here, Grandison Harris. Who better to rob graves in a Black cemetery than a Black man? And how else does a Black man warrant year after year appearance in the graduation picture for these doctors? There's no other way he would make this picture unless he was critical to their education, and he was critical because he was a grave robber. And then in the 90s in Virginia, rather in the 60s in Virginia, this man fell off of a 3-foot wall, hit his head, and within 24 hours, they had harvested his heart and transplanted. And again, no permission from the family, very suspicious undertaking. They're writing books and stuff about it. And so who knew about that? His family knew about it. His coworkers knew about it. His neighborhood people knew about it. So how did that reflect on the hospital, on doctors in general? So these prior mistreatments are firmly grounded to many African Americans' perspective. Not all African Americans, but many of them's perspective on medicine, on all these things. And so we see articles about distrust, the healthcare system, that people don't trust things like the coronavirus vaccine, or the information that they hear about the coronavirus itself. All those things are fueled by these examples and many, many more that I don't have the time to go over, that impact people's mistrust, that you have to try to build trust. And so that low trust leads to poor adherence to a doctor's recommendation to take blood pressure medicine, poor adherence to a follow-up to getting a colonoscopy, poor adherence on all the screening things that we do to try to prevent. And then once you have diabetes or hypertension, poor adherence, poor trust of the provider. I'm not sure this person has my best interest at heart. And why is this kept? It's amazing to me, the people that do trust, a medical sort of system that has done this in the past. I not only do I understand it, I wonder about the people. I come from a family, one side of my family trusts doctors, my other side of the family didn't. And I was like, well, why, what is the difference there? But that leads to things. So when you think about patient-centered approach, you must consider this and these other histories. You want to know that there are people have a generational mistrust. When they sit around the dining room table, they're not talking about doctors in a favorable way. They're not talking about medicine in a favorable way. They're not talking about any of these things, and it is generational, right? And then when I talk to providers, acknowledging this is important. And this is where the history issues, acknowledging that this happened is, and I try to show these pictures because it did happen, right? It did happen. You could say it happened long ago, and it did happen long ago, but it did happen. But there are still people who will not acknowledge that this happened, and that's a barrier. Well, it didn't. I wasn't involved. No one's saying you were involved. Just know that there are people like you did this to people like me, and so that's what I bring to the table. And building trust is not something you can build in one sitting with anyone, right? You don't meet somebody and marry them. You have to build trust from that area too. So it's important that we sort of understand that what sort of patient, is this a sort of patient that distrusts doctors? Is this the sort of patient that has been abused? Is this the sort of patient that hasn't had money to do things? Is this the sort of patient who's more concerned about their children and their welfare than their own? That's the type of things we need to think about when we're thinking about patient-centered care. I know that was dizzying, but they gave me 11 minutes and I was determined to get it done in that time.
Thank you, Dr. Hall. Any questions?
I shut everybody up. They're really just sitting back saying, what did I just see?
Dr. Hall, can you share a little just about the center and what you're working on there?
Yes. So the Center for African American, UH Center for African American Health, we're trying to take some of that, some of this trust issues, but also a lot of the clinical care issues that I spend more time really talking about, the differences in the treatment of hypertension, the breast cancer, for example. There is a sort of an explanation on why African American women get certain types. They can tend to get the hormone negative ones, and there's less treatments for that. And so, we're really trying to establish a center that's going to give best practices, best care to African Americans in Northeast Ohio based on research outcomes. And then again, I'm with Professor Hoffman. It is a social construct, but if you put rats and aggravate them all day, they have a shorter lifespan, right? If you torture whatever organism it is in any light way, that impacts their health. And so the health outcome is a way, it's a sort of a way to categorize them. But it's also important that higher socioeconomic status African Americans still have an increased problem with their health. They still have increased infant mortality. They still have increased diabetes. They still have increased prostate cancer. So I'm still at a much higher risk to die. And I'll admit I'm an upper class African American, from an economic standpoint, but I'm still not gonna live as long as the poorest white person or the poorest Asian American person. And so that's the type of thing that we're going to try to really address, being deliberate about providing the care and knowing that our providers have done a little extra reading as it relates to best practices on knowing their own biases, knowing how I address people with the patients come with all these biases that many of them aren't fair, but I sort of hope I share with you why they come with those. And then we also show up with biases that may or may not be fair. And so it's one of those things that we if you're aware of it, you can kind of counteract. I have biases, and when people say, I treat everyone the same, I'm like, get away from me, because you're doing all kinds of damage. If you treat everyone the same, you're doing all kinds of damage. That's not the approach. You don't spend 10 minutes telling someone to stop smoking if they don't smoke, right? You don't tell a vegetarian, stop eating meat. Well, you don't eat meat. Well, let's move from there. What are you eating, eggs all day? You're going to tailor your discussion to the patient. That's the patient-centered approach, right? And so that's when you learn and find out about what the patient's history is, what are their dynamics, listen to them, and then arrange your intervention to best address that.
Thank you, Rachel and Dr. Hall. Clara?
Dr. Hall, thank you very much. That was really incredibly helpful. And I would just like to ask you if I could reach out to you. A group of faculty and myself, we teach a module in the collaborative practice class that's for health professions education. And our module is called the History of Cleveland. And it isn't meant to be a history class. It's meant to be, how is the history of Cleveland related to the health disparities that doctors see in their offices? And of course, we give them reading on redlining and all, and unfortunately the reading is sort of long and sort of dry. And I would love to reach out to someone like you to get maybe some more engaging resources for the students. They can't read more than like an hour worth of stuff. So basically we need something more engaging for the students to really get this point across. And I think the kinds of slides you just gave us is perfect. So if I could reach out to you after this.
Absolutely. Just email me away. No problem at all. I'll be happy to help.
Thank you. Oh, now you got lots of questions in the chat.
We have one in the chat from Michelle, and it reads, what are some of the initial steps we can do now to help build the trust relationship between doctor and patient?
Well, I mean, what I tell myself, and as you can tell, I'm a talker, right? So I tell myself when I go in, shut up, right? Shut up, and because you're coming in at an advantage, you're the doctor, I'm the patient. And so I try to bring myself down and say, I grew up in Cleveland. I grew up right up in St. Clair. I went to Cleveland Public Schools, and I'm just like you. And tell me about yourself. And so that I'm really interested, because that really does give me the groundwork that I'm interested in something other than what you're complaining about today. And so I tell the residents that rotate with me, I make a point of not getting to the point with every single visit, unless the person's sick with a migraine and laying there with sunglasses on, I'll get to the point then. But otherwise, I'm always going to start with the Browns, unfortunately, or with the Cavaliers or the Guardians, or the weather or something, just to bring them down. What you do this weekend, what you eat, where have you been good, what's a good recipe? And I'm actually interested. I get good recipes from people. And but it also tells me a lot about what their life is like and the things they do. And then that allows me to give better care. So if you're building trust, if you're deliberate about it, it takes a little bit of extra time, a little bit. It's not as much as you think, but to say, I'm going to build trust in this person, and this person is not going to take any medicine if I throw 3 different medicines, even though that's the state of the art. That's what the state of the art says that I should do as a practitioner for a person with diabetes, right? This person doesn't even believe they have diabetes, and I'm gonna give them 3 different pills to take once a day. Let's just try with one, and let's see what you think about it. And then I'm really been working on lately on this collaborative decision making. Like, I already know what I want to try, but I was like, let's hear the options, let you know what the options are in my head, and let's together make this decision. And so I've been finding that people are liking that better, even though they're picking what I had picked quietly to myself. I'm giving them the options, and that buy-in is seeming to make a difference. But I'm still a work in progress right now, so I'll know more 10 years from now than I do now.
Thank you, Michelle. And Rashida?
I can go first. I see the Cutler Center as bigger than just a center that's focused on equity. I see it as possibly changing the culture of healthcare. What is your vision in regards to the influence that the Cutler Center can have on the culture of medicine?
Well, I think one of the things we're doing is, which people haven't done in the past of medicine, is really find out from the patients, how do you like to be treated? And I found that, they said one of the things they're going to do with the new Cutler Center is that someone's going to come and grab you out of the waiting room and bring you in privately. And so when I had to get my tobacco screen done, when I first started here last December, and I went to the hospital and I sat in this great big room, and somebody came to the door in front of 20 people, said, Greg Hall, Greg Hall, Greg Hall. And I was drunk each time. I didn't want to get up and answer, right? But it's a man's response. You know what I mean? It's like you put me on Front Street, and I slunked over, and she handed me a urine cup and all of that, And so men don't handle that well. Now, women wouldn't have thought anything of it, right? But it's just that was like, ooh, And so I had to make an appointment to see eye doctor. I spent 15 minutes trying to do that. I almost quit. Forget it. I'll go blind. I can't spend 15 minutes trying to make it. Do my patients have to do this? The answer is yes, right? So we have a navigator that says we could try to make this easier, because we know that, certain things as it relates to our health, we're kind of ingrained in us that our health kind of comes last, and money and providing kind of comes before that for most, not all, right? And so we tend to take a second place on our health. And so the Cutler Center is really saying, how can we make this so that you don't want to not come? And how can we make you follow up with your colonoscopy when you need it, not 5 years late? And so I think and we did a lot of focus groups to see what they like and what they don't like. And, there's going to be a pool table. Who knows if anybody's going to play pool? But the Cutler Center at the Hoosier, there's going to be a pool table there. There's going to be foosball. There's going to be, things that we think men might be interested in. And because we've talked to them, and we're trying to respond to that. And I think in the past, hospitals sort of just said, this is that's when people were in wards and they were all in one big room. No one was asking the patient if you want to be in a big room or, but now that this is really something that's driven more by patients and by men and by data in terms of customer service. I think we're putting customer service above actually patient care, to be honest with you. And because that is how you improve patient care, by really being attuned to what's comfortable, what makes people comfortable.
Thank you.
Thank you, Rashida.
Yeah, and actually, you pretty much answered most of my question about some of the initial steps that we can do. But one of the things I was thinking about, though, is how do we even get people into the door? So, we deal a lot with trying to work with people who have substance abuse or mental health, who are interested in getting treatment. So how do what are some guidelines to try to even get people to start talking about it, to even make that appointment, let alone get into the facility for those services?
Yeah, it's not easy, right? And that is the problem. I still have patients call me and tell me, John Doe has a terrible drinking problem. He's drunk all the time. He's got a DUI. When he shows up and I go in the room, any problems with alcohol? No, nothing at all. So I can't, and then the family says, don't tell him I called, right? And so how do I address a problem that everyone is saying is a problem, but the patient's not saying it's a problem, much less agreeing to go somewhere? So it's not an easy approach, but again, as you're able to build trust, that's what I tell myself. I'm not like lost. It's like, I've got to trust, let this person know that I'm flawed enough you can share your flaws with me, number one, and that you can trust me with that information. And then I'm always going to have your best interest at heart. And so when I've done that, it surprised me that people will start to share with me down the road. Yes, I do have a problem. Yes, this is an issue, but I'm not really ready to do this or that. I was like, that's no problem. I understand. I have issues, So it's one of those things that I try to make it more of a, we all have problems, which guess what? We all have problems. And when people try to give you the impression that they don't, they're just misleading you. We all have problems. So when someone comes to you with a problem, you're just in here with a person with problems too. And I think maybe people are more apt to sort of share or be open to what they might do about their problems. If you're not coming from a place of super strength, I that has no problems will help you with all these problems. And so that's really the more of the issue than anything.
Thank you. So instead of moving to breakout, since we have 9 minutes left, I want to continue along the topic of trustworthiness, and I'll share this graphic that has the trustworthiness equation, and we can kind of talk about it as a group. So we have credibility plus reliability plus intimacy plus self-orientation, and that equals trustworthiness.